something. Hello, testing. No, Joey is hearing sounds in her head. Good. Maybe it's just like a delay. Hi, sorry for the delay. There were some technical errors. If there are any questions during the talk, you can post your question on Facebook or on YouTube in the comment section. With no further ado, I would like to pass this talk over to Dr. Siti Zubaidah.
Okay, thank you, Ms. Hautai. Assalamualaikum warahmatullahi wabarakatuh, and good evening, everyone. First, I would like to thank Sabah Surgical Society and Gleneagles Hospital for inviting us to the Surge Talk series for primary care. So my topic today will be on approach to patient with breast lump and introduction of Pink Ribbon Center, Hospital Queen Elizabeth II. Okay, first we start with breast lump. Why is it important is because most of our breast cancer patients, they come with breast lump. And breast lump is the growth of tissue develops from the breast. It's either from the lobules, ducts, and also from the fatty tissue. Breast lump it can be either benign or malignant. Benign breast lump, it can be either fibroadenoma, fibrocystic disease, or some infection like bacterial mastitis, duct ectasia, tuberculosis, chronic granulomatous mastitis, or if it's related to pregnancy, it can be like galactosil or abscess, or it can be fat necrosis due to injury. The common benign cause of breast lump is like fibroadenoma, as you've seen here, and cystic breast changes. And duct ectasia, they usually presented with nipple discharge, abscess, fistula, nipple restriction, and mass. In duct ectasia, normally the nipple discharge will be from multiple ducts. Galactosil can present with breast lump. It occurs in lactating mother. It occurs when the duct is obstructed and the milk is accumulated. We diagnose this by doing ultrasound, and we can aspirate it to relieve the pain. So intraductal papilloma, the presentation will be bloody nipple discharge from single duct. And for malignant breast lump, it could be either carcinoma, malignant phylloides, lymphoma, or carcinoma. And breast cancer is a malignant growth that begins in the tissue of the breast. And breast cancer, as you know, is the most common cancer in women. In US, it affects 1 in 8 women, and in Malaysia, it affects 1 in 20. So from our Sabah Cancer Registry from 2012-2016, we can see that breast cancer accounts the most common cancer. It's around about 13% from all cancer. So when you get a patient with breast lump, we need to do triple assessment. First assessment is by history and clinical examination. Second is imaging, is either ultrasound or mammogram, and third assessment is biopsy. So in the history taking, what is important is you identify which patient in the high risk group. Okay. High risk group, the most important, you must ask whether there's first degree family with breast cancer. Is either mother, the siblings, or the daughter, and whether patient previously tested whether they are carrier for BRCA1 or 2 gene mutation. So breast lump, as I mentioned just now, is the most common presentation for breast cancer. And when you find a breast lump, 80% is normally is benign, but before you subject it to benign, we must investigate it. And other signs are like any nipple changes. As you can see here, there's a excavation of the nipple. It's the normal nipple, you can't really see. And from this patient, there's a nipple changes, whereas we can see some ulcer beneath the nipple. This patient, when we biopsy, it turned out to be invasive carcinoma. And Paget's disease, you will find changes of the nipple, and you can see here a bit of changes. And when we did the mammogram, we found out he also have underlying invasive carcinoma. And here the other case is very extensive Paget's disease with underlying invasive carcinoma. So what we do is she had a mastectomy and axillary clearance. Okay, as I mentioned just now, other signs are like bloody nipple discharge from the single duct, whereas duct anesthesia, the nipple discharge more from multiple ducts. Okay, again, if you find a patient who presented with single nipple discharge from single duct, you must be more careful. And other signs are like nipple retraction and skin dimpling. And one of the signs also is pudorangea, which occur when there is a lymphatic obstruction. And lymphedema when the cancer already spread to the axilla. Recently we have a young lady presented with came to the hospital with upper limb swelling, and she still didn't tell about her breast lump until when we did a ECG. Then only we found out that she got a fungating breast tumor. And this another patient who came late with fungating breast cancer. You can see the ulcer with the slough and bleeding. Normally if such a patient came like this, they will get anemia. And other types of breast cancer, we call it inflammatory breast cancer. We find a patient will complain of very sudden redness of the breast, and it's associated with itchiness. So this inflammatory breast cancer, we have to differentiate with mastitis. In mastitis, the inflammation is more like in one quadrant rather than the whole breast. So from the latest CPG for management of breast cancer, these are the criteria that we need to really look into when we find a patient that are more than 35 years old with sign and symptom of any signs of symptom of breast. And the second is high risk group with sign and symptoms, and the third criteria is patient with clinical sign and symptom of malignancy. So these three groups of patients, they need urgent referral to breast clinic. Urgent referral means that we have to see them within 2 weeks. So So the second assessment will be imaging, which is ultrasound, mammogram or MRI breast. For ultrasound, we do for patients that are less than 40 years old, and for more older patient, we can do mammogram with ultrasound. And MRI breast, we can do if the mammogram is not really conclusive or patient with breast failure. Okay, from ultrasound we can assess whether the lesion is either solid or cystic, or there's any features of malignancy. So mammogram is type of X-ray, and what we can see from mammogram is a microcalcification. Microcalcification is the early signs of breast cancer. So mammogram plays a major role in early detection of breast cancer, and it can detect 75% of cancer at least a year before they can be felt. Okay. So mammogram uses low dose of ionizing radiation, which may be harmful, but the benefits of it is far outweigh the risk and inconvenience. So there's two types of mammography examination. First is screening, and second is diagnostic. So for screening mammogram, for general population from the age of 50 to 74 years old, we can do every 2 years. Okay. And for women with high risk of breast cancer but with no genetic variants that has been identified, the screening mammogram, we can consider it from the age of 30. And mammogram should be performed annually from the age of 40 to 59, and from 60 years old we need to do it every 2 years. Whereas women with BRCA carrier, we suggest to do annual MRI, which should be offered from the age of 30 years old to 49 years old, and mammogram annually from the age of 40 to 69, and 2 yearly mammogram from 70 years old onwards. So diagnostic mammogram we perform for patients with symptomatic, either breast lump or nipple discharge or pain. So get the two views, craniocaudal and mediolateral obliques. This is the machine, mammo machine. This two views. This is how we do the mammogram, craniocaudal and mediolateral oblique. So what we can see, you can see here there's a microcalcification from, you can see it almost involving the whole left breast, and you can, from mammogram you can assess the mass, the characteristic of the mass. So third assessment is biopsy. There's few types of biopsy. The first is fine needle aspiration cytology, core biopsy, excision biopsy, and incisional biopsy. Fine needle biopsy we can do for cases like fibroadenoma, okay? And core biopsy we need to do if we suspect malignant. Okay, normally we do under ultrasound guided. And incisional biopsy when the tumor have been fungated, and excisional biopsy means we take out the whole lump. Okay, this male breast cancer accounts about 1% of all the breast cancer. Okay, so when you find patient, male patient with symptoms or any symptom on the breast like ulcer or a pain, you have to investigate. Don't just ignore it. like this patient, we have been investigated and mastectomy have been done for him. And another 69 years old man with right breast cancer, and we did a mastectomy. Another advanced breast cancer, and also another lady with breast cancer mets to skin, lung, liver and bone. So breast cancer can spread through blood and lymphatic. Patient can come with bone pain and fracture, and if spread to the spine, patient can present with paraplegia, weakness and numbness, and they can present with shortness of breath due to pleural effusion, jaundice from liver metastasis, and headache or loss of consciousness from brain metastasis. Next, after we have diagnosed breast cancer, we have to stage the disease by doing CT scan normally. And once we got the diagnosis, the treatment is actually breast cancer treatment is multimodal, which can comprise of surgical, chemotherapy. Chemotherapy we can give it before operation, that we call it neoadjuvant therapy, radiotherapy, hormonal and targeted therapy. So today I will just talk about surgical management. So for the breast, we can do either mastectomy or breast conserving surgery. And mastectomy we can do with or without breast reconstruction. And axillary surgery is either lymph node dissection or sentinel lymph node dissection. So how we choose is depends on ratio of the breast size and the tumor size. If the breast is small and the tumor is small, sometimes we couldn't save the breast. We need to do mastectomy. And so this how we do mastectomy. Actually, at the end of the operation, there will be just a scar and a flat chest. So for some women, they can use a breast prosthesis to get a symmetry of the breast. And you can see here, there's a 67-year-old lady with presented with breast lump, 1 year breast lump, and when biopsy, it came back as estrogen negative and HER2+, and she had chemotherapy. Then she responded well, and she had surgery after the chemotherapy. Breast conserving surgery is normally we have to give radiotherapy to eradicate any microscopic residual disease, and this normally we do for early breast cancer. And the goals of breast conserving therapy is to provide the survival equivalent to mastectomy, and it is cosmetically acceptable and with low rate of recurrence in the treated breast. Some contraindication for breast conserving therapy is like when the lesion is multicentric, when there's diffuse microcalcification or mammogram, or the history of prior radiotherapy, or patient is pregnant, and patient who are persistently positive resection margin despite multiple attempts at re-excision after breast conserving surgery. These are all the contraindication for breast conserving therapy. And for oncoplastic breast surgery, there are many types of oncoplastic breast surgery. What is good about oncoplastic breast surgery is we can resect more breast tissue with good cosmetic outcome. There's a patient who we did J-plasty. The lesion is behind the nipple area complex, and after we have resected the tumor, we reconstruct back the breast. Okay, this is the photo post-operatively. Another type of oncoplastic by surgery, this is round block technique. The lesion is at the 12 o'clock. We resect it, and post op you can't see really any scar. So another J-plasty. Okay, breast reconstruction. Normally it provides a psychological, social, emotional and functional improvement, including improve the psychological health, self-esteem, sexuality and body image. We, from our practice, how we choose a patient with breast reconstruction is we offer for young patient less than 50 years old, and we choose patients that are not locally advanced or advanced breast cancer, and the time of surgery is either delay or immediate breast reconstruction. It depends on the risk of recurrence of the patient. So the type of reconstruction can be is either flap or implant breast reconstruction. Implant breast reconstruction normally for patients that are thin and nulliparous, and it can be either immediate or delay. So these are the patients that we have done implant breast reconstruction. This patient had previous right breast cancer. She had a mastectomy, and on follow-up she had a new ductal carcinoma in situ in the left breast. And what we did is we did a mastectomy, we implant breast reconstruction, and also delayed implant breast reconstruction in 2 stages. So we put a tissue expander first. So like I mentioned just now, it's either immediate or delay. The immediate breast reconstruction is done during the same surgery as the mastectomy, whereas the delayed reconstruction is done months or years after the mastectomy. Okay, it can be either flap or implant, and the aesthetic result, psychological effect and cost of the breast reconstruction are better with immediate reconstruction, but the risk of surgical complication is less with delay reconstruction. These are the patient with delay breast latissimus dorsi breast reconstruction. For the left mastectomy, we did the latissimus dorsi. This is the pedicle, how we did the pedicle LD flap. We dissect the latissimus dorsi flap and rotate it to the front. And it can be combined with implant to get more volume. Another patient with latissimus immediate latissimus dorsi breast reconstruction. Tram flap can be either pre-flap or pedicle. For our side, we only do pedicle. This is the patient with pedicle tram. Okay. Next, I will give a talk on introduction to Pink Ribbon Center. So globally, more people are surviving from breast cancer due to increased awareness and also increased screening program for breast cancer. And it is expected in 2050 that 9 in 10 women will survive in 10 years. But survival in Malaysia is one of the worst. Where in the study by the Economist Intelligence Unit in 2016, we found that in Malaysia the 5-year survival rate is only 49% compared to 80% in Singapore and 92% in South Korea. And the major reason for this is late presentation and poor adherence to evidence-based treatment. And studies in psychosocial factors showed that fear, poor health education and lack of empowerment among Malaysians are major reasons why they delay or default treatment. In order to address these challenges, Cancer Research Malaysia identified the patient navigation program as a potential community-based solution to improve the Malaysian survivorship of breast cancer. So patient navigation program is a program spearheaded by Cancer Research Malaysia in collaboration with the Ministry of Health with the aim of managing breast cancer patients in our country, especially those from the B40 community. So a little bit background on patient navigation program. It was first introduced by American oncologist Dr. Harold Freeman in 1990 at Harlem Hospital Center in New York City to reduce the disparity in assessing cancer treatment, particularly among the poor. So what is our goal is to improve the 5-year survival rate from 39% to 70%. There's 3 factors that we have to look into to improve the 5-year survival rate. The first is to provide the screening to patients regardless of ability for them to pay for the screening mammogram. And second is to eliminate any barrier to screening and timely diagnosis and treatment. And third is to increase the outreach and public education. So, patient navigation program, the vision is to improve the survival rate for breast cancer patient, and the mission is to downstage the advanced cancer. So there are 3 phases of patient navigation program. Phase 1 is in the hospital level, whereas we set up the Pink Ribbon Center, and phase 2 is at the clinic kesihatan and clinic is in the primary care level, and the third phase is in the community intervention. So what we want is we want to reduce the stage 1 and 2 60% to increase the stage 1 and 2 from 60% to 80%, and to downstage the stage 3 and 4 from 40% to 20%. So in the phase 1 in the hospital level, our goal is to get a timely diagnosis of the diagnosis of breast cancer, and to complete the treatment, reduce the default rates, and to increase the supportive care of the patient. And at the primary care level, what we want is a rapid referral to the hospital, to our Pink Ribbon Center, and to reduce the hospital referral default rate, and also to increase the breast cancer screening at primary care. Whereas in phase 3 in the community, our goal is to increase the health knowledge, particularly to recognize the symptom of breast cancer and to improve the efficacy of referral pathway from any localities. So, Pink Ribbon Center, Hospital Queen Elizabeth II, we are the one-stop center. We set up is to help breast cancer patients to navigate their way throughout their treatment. And what we do is we will improve the timely access to diagnosis and treatment. We reduce the default rate, and we will address the barriers that faced by the patient to get the treatment and to increase the supportive care for patient. What I mean by improve timely access to diagnosis and treatment is when we get a referral to Pink Ribbon Center, on the first visit we will do the triple assessment. Okay, from the clinical examination and history taking, and we will try to get on the same day get a mammogram and ultrasound and together with the biopsy. We are very fortunate to have a breast radiologist in Queen 2, Dr. Jane. So our access to mammogram is we can get it very fast. And after, the second visit, the biopsy will be ready. The most is 14 days. We will get the biopsy. So during the second visit, we will get the news, and we will stage the patient. So we will get the appointment for CT scan. And after that, the third visit, after about 2 or 3 weeks, we can plan whether patient will go for surgery or for chemotherapy. So if you can see here, it will take less than 3 months to complete the diagnosis and treatment. So in Pink Ribbon Center, we manage defaulters. As you know that defaulters is you have to know which patient is a potential defaulters. These are the characteristics. I just give you few like belief and usage of traditional complementary medicine, and with patient with poor economic background. So what we do, we will give counseling, we will do a phone, telephone follow-ups, and we will give patient and caretaker education to advise them, counsel them the importance of getting a treatment, and sometimes they give can go for home visit. So we will also address any financial barriers of the patient. We have petty cash, and we put all sorts of channels to help patient financially. It's either from Magna, from Pusat Zakat or Baitumal, and also from My Salam. So Pink Ribbon Center in Malaysia, so far there are 4. Okay, it started with Hospital Tunku Ampuan Rahimah in 2015 and it expand in 2020. Queen 2 Hospital Tunku Jafar in Seremban and Hospital Umum Sarawak. So you can see here our program. In Queen 2, the days to set up is like almost 2 years, okay, and we in 2 years, 2020 and 2021, we managing 398 new breast cancer. And the impact of this program, and you can see from Hospital Queen 2, before PRC set up and after we fully set up the center, the default rate from 15 dropped to 2, okay, 2 patients. And the completeness of diagnosis and the results, you can see here, mammogram and ultrasound, we improved from 58% to 64% in getting the mammogram and ultrasound. And the biopsy, we could do biopsy from 75% to 91%, and the result of the biopsy we could get within less than 7 days, increase from 35% to 48%. And to start the treatment, is either surgery or chemotherapy, we increase from 40% to 60%. This is despite the MCO. We managed to meet the goal for the timely access to diagnosis and treatment. So we start the patient navigation program in Queen 2 since February 2018, and it was launched by Top Point Haja Nolida on 4th October 2019. For time being, we have 2 medical officers, 3 specialists, 2 nurses, and 2 navigators from Cancer Research Malaysia. So these are the launching time on the 4th October 2019. We don't have a dedicated space. The Pink Ribbon Center is just in our existing breast and endocrine clinic. So these are the criteria for rapid referral. First is a breast lump that clinically suggestive of malignancy. Patient who are more than 35 years old. Patient with imaging with BRAF 4 or 5. Patient with biopsy proven breast cancer, and also patient who are non-case of breast cancer and who have defaulted treatment, and patient are pregnant with suspicious breast lump. So how to refer to us? You can contact 2 of our medical officer, Dr. Fazila and Dr. Shuhada. So actually we have a referral template. Normally we use it for MR from district and clinic kesihatan. But for GPs, we would like you all to give us a call. Then you can fill up this template and WhatsApp to them. Then we will give them the appointment date. Because all this while, what happened is, from GP, you write a referral letter and ask patient to come to our clinic to get appointment. Okay? This sometimes it can cause problem to patient, and so we can improve a bit. Just give us a call and we will give them appointment date. And sometimes we found out that GP will ask patient to go to clinic kesihatan first. Then from clinic kesihatan only refer to us. So it's a bit delay. So I will suggest that from GP can directly refer to us. It will save time. So we are located at the surgical clinic, breast endocrine, third floor, Queen 2. Our office time is Monday to Thursday, 8 a.m. to 5 p.m. So can contact us by calling this direct line. Okay, you can see the line, and it's our email and our Facebook. So for phase 2 and 3, we are focusing on 2 groups. Okay, first is the healthcare professional, which are the medical officer and the paramedics in district hospital and clinic kesihatan. And the second groups are the public. Okay, so what we do in there's two days of our outreach program. So on the first day we will go to the district hospital. There's a lecture given from surgery, radiology, pathology and oncology, and to give education on how to detect breast cancer and also how to refer to us. And the second day we will go to we do a public breast cancer awareness program. This program we collaborate with Kinabalu Pink Ribbon. We will normally there about 150 participants will come, and what we do will check the breast and we'll arrange the mammogram appointment for those women yang indicated to do mammogram, screening mammogram. So this year we have gone to few districts, okay, from January to September, and the last one is we went to hospital Kudat and Kudat. So these are the numbers of participants that are involved from the healthcare profession and the community. As you can see here, the number of breast cancer in Queen 2, it has been increased over the years, and for the past 2 years, because of the MCO, the numbers is reducing. And as of today, we have 180 new breast cancer patients. This is because of the outreach program that we have done. We're getting more referrals. So if you see here, the stage of our breast cancer from in 2019 and 2020 is around 60%, stage 3 and stage 4. So with this effort, we hope that we will get a lesser number for stage 3 and 4 patients. So these are the latest breast cancer awareness outreach program at Kudat. Okay, this is the first day in hospital Kudat, and this is the second day at the community at Kampong Ayer, 9 and 10 September. And with that, I thank you.
Thank you, Ms. Siti, for your very insightful talk on how to approach breast lumps, as well as the introduction to the Pink Ribbon Center in Hospital Queen Elizabeth II. There are a couple of questions from the audience. The first one being, what is the acceptance rate of breast reconstruction compared to mastectomy? Are patients able to accept the idea of breast reconstruction now compared to a traditional mastectomy?
What is the acceptance?
Are patients able to accept breast reconstruction as compared to the traditional mastectomy?
Okay. As I mentioned just now, when we have a patient, they are younger means less than 50 years old, we will offer them breast reconstruction if they are suitable. And after talking, counseling, they are very acceptant. Yeah, they agreed with the breast reconstruction. And the type of reconstruction, it depends which is suitable for them.
What is the estimated cost of breast implant surgery in HQE2?
Okay. Okay, since this is a government hospital, patient need to buy the implant, which costs 3,500, and also include the bra and a binder. It all costs about 4,000. The hospital charges is not much, it's around less than 200 ringgit.
One final question. What is the estimated waiting time from the first visit to the Pink Ribbon Center up to surgery?
For suspicious cases, we will give appointment within up to 2 weeks. And for patient to get their treatment is up to 6 weeks to 8 weeks. Yeah. It won't be more than 3 months.
All right. I think that's about all. I think we can wrap up today's session. Thank you very much for your attention, and thank you to Dr. Siti for the talk today. If you have any further questions, don't hesitate to contact us at the numbers that were given just now at Hospital Queen Elizabeth II. Thank you.
Dah. Thank you very much.
Thank you.